So it is really interesting, the money mindset pieces that we have to to overcome in order to be successful. And even when therapists choose to finally up their prices or to finally charge what they are worth, right? Because we have an insanely specific set of skills that are really, really, really beneficial to a million populations, but we do not look at it like that. And they would have no idea what they were coming in for. They would just show up for an evaluation and be like, wait, what? What are we doing here? They had absolutely no idea what a pelvic floor was. They had nothing. And so the impact that we are creating as therapists is bleeding into the community, which is absolutely incredible because that is where it needs to go. But also because OTs tend to feel a little more like, well, I don't want to feel like I'm just I'm like a PT in sheep's clothing, right? Like, I don't want to feel like I have to fit into this box. Right. So how can I feel like an authentic OT doing pelvic health? And so it's as Lindsay Vessel says, a double horn unicorn. So
Rebecca Seagraves here with Danika Viola. Danika, thank you for coming on and talking about this hot topic. I'm ready to get into it.
Yes, thank you for having me. I'm so excited to talk about this.
So cash pay pelvic health, why in the world is it so controversial? I don't understand the problem.
I don't either. I think people immediately kind of jump to like, it should be affordable. It should be obviously equitable access to everyone. And I think that a big piece of misconception out there is that cash-based pelvic health does not have to be unaffordable, and it doesn't have to be inequitable. Like, it can absolutely, address the needs of a ton of different populations while also giving the practitioner a lot more freedom to practice how we were taught to practice in school, and give our patients those optimal outcomes and provide them with higher quality services, because unfortunately insurance does make a huge difference when it comes to the quality of care that you're able to provide. Your hands are kind of tied half the time, especially when it comes to pelvic health.
Totally. I mean, people actually think I'm like biased towards insurance-based care because I talk a lot about occupational therapy and physical therapy in the hospital after birth. We know that most services in the hospital are covered by insurance.
Yes.
But what people don't realize is that I know that once those individuals leave the hospital, they're waiting 6 weeks. They're waiting sometimes 35 days for a pelvic health therapist schedule, who accepts insurance, to open up so that they can actually get care. And we know that for the majority of births, just speaking about that population, they're not seeing a pelvic floor physical therapist or occupational therapist within a timely enough manner to actually benefit from accessible care. So what are you talking about? Like, is this, I mean, I don't, right?
No,
And I know you mentor
exactly.
and coach. You coach like therapists who are probably trying to move out of insurance-based practices where they're seeing a ton of patients and they want to start their own business. They want to provide better care, but they also are having a lot of just maybe doubt, mindset issues around charging for their services. Do you not?
Yes, 100%. And it's so interesting how that money mindset is such a big piece of an obstacle that I think therapists across the board face when it comes to starting their own practice and pricing out their services. Because oh my gosh, probably 7 out of 10 of the therapists that I mentor for business coaching tend to be like, well, do you think like $100 an hour or $85 an hour is like okay for an hour of therapy services? And no, like, what are you talking about? So it is really interesting, the money mindset pieces that we have to to overcome in order to be successful. And even when therapists choose to finally up their prices or to finally charge what they are worth, right? Because we have an insanely specific set of skills that are really, really, really beneficial to a million populations, but we do not look at it like that. And so we're kind of taught to be like over humbled by school, by insurance-based models, by all these things. And so even when they raise their prices, it's really interesting to see the confidence finally come up as patients, as, potential leads are like, oh, okay, I'll pay that. And they're like, wait, really? Oh, really? And
Amazing.
the thing is that I try to tell them is like, you don't know everyone's financial situation. You can't, price yourself out on like a guess of what your area can afford because that's not how it works. So you don't know if they have, if they're a teacher and they don't make that much money, but their benefits are phenomenal and they have out of network benefits that you can provide a super bill for. I have a friend who has a $500 copay for out of network and then it's 100% covered. So for her going out of network, I know she's a teacher in New
Wow.
Jersey. So for
Yeah.
her going out of network is not a big deal because she's like, I would rather pay the $500 deductible versus no deductible, but get 10 times better care and get out of there quicker.
Okay, just hold on. When you're first coaching, because I want to bring a special guest up to stage to talk about this with us. When you're coaching people, they want to charge what again for their
Like
services?
between 85 and probably 115 is like the most common numbers that I hear
Okay, for an hour of care.
for an hour of care.
Do you find that insurance-based therapists who are coming from that model who have been paid, and I kid you not, I just saw this ad just recently. It was for either an OT or PT. I think honestly, it was probably a PT. That's how I was a little surprised because
Yeah.
we're going to talk about this too in terms of what OTs get paid versus PTs and insurance-based practices, right? But it
Mhm.
was for $33 an hour, and the max was $50 an hour.
Yes.
And I think about that a lot from someone who's coming from that care model, right? And getting paid
Yeah.
that much and sometimes being asked to see several patients within the hour. I know for a fact that there's many clinics who are operating on 30-minute time frames to see pelvic health
Yeah.
patients. So for
Yep.
those particular therapists, $85 an hour sounds like a lot because they have no idea what the insurance company is actually getting for their services.
Yes. Yes. And the thing is that even if so let's say you pay yourself $85 an hour, and let's say you really like the profit first method when it comes to finances and budgeting,
Mhm.
and you take one of the higher owners pays of 40%. If you're charging $85 an hour, that is $34 an hour, and you still owe 15% on taxes on that. So
Right.
that's not $34 an hour, right? Like, that is a lot less money than what you are actually going to make at an out of network or a outpatient clinic taking insurance.
Right.
So what I try to tell people is like, what do you need to pay yourself, right? Like, are you going to
Mhm.
be somebody who charges higher, has less clients? Are you going to be somebody who just charges higher because that's what you want to do and you're going to have the same amount of clients? Like, what are your goals? What are your goals for your income?
Right.
Because that is going to basically drive a lot of the finances when it comes to creating your business and creating your pricing structures. And there are absolutely ways that you can create it so that there are affordable ways of doing it for the patient. And I say affordable as in people who have financial barriers, people who have travel barriers, anything like that. We offer so 10% of every session, of full price session, goes into a kind of a scholarship fund for patients to address sliding scale, to be able to provide sliding scale and pro bono services. Anything that we sell merch wise, 100% of that goes into sliding scale and pro bono services. And so if somebody calls us and is like, hey, listen, I just had, a kid. I am super broke because I have no maternity leave that's paid and I don't know what to do. Um, the finances are not going to be a barrier because we can cover you. But that is something that a lot of people, I think, don't even consider because if they have insurance and they went to an out of network clinic, they may still end up paying their entire deductible which would be money out of their pocket, even if it's an HSA, because we can take HSA too. So they would still end up paying $200, $150 per session until they hit their network deductible. So
Yeah.
it can literally end up being cheaper for the patient,
I
which
was
is
actually, yeah, I was in a hospital-based clinic. My deductible out of pocket was $228, and I was never gonna meet my I don't think I was just ever gonna meet it. You
yeah.
know, it was like a ridiculous, like, $3,000, and I was just like, "Okay, so I'm paying more than
Mhm.
our clinic's own cash pay rate. Like, what sense did that make?" And so we're
That's the
starting out this
issue.
right? I mean, we're starting out this conversation, we're talking a lot about the provider, but what people don't understand with pelvic health care is that you're seeing a very specialized set of providers that there's not a lot of us, right? Even
Mhm.
if we combine all the OTs and PTs, and that's even controversial there too. Gonna get into that a little bit there. But even if you combine, you know, all of the practitioners that could provide pelvic health therapy services,
Yeah.
you're still waiting a significant amount of time, and you're lucky to even find one in your zip code nowadays. And so we have to talk about the providers first, what they're charging and how they're actually filling their own cup, because we don't have very many of us. And if we're burning out, that's a
Yeah.
disservice to the patient. It turns always as a disservice to the patient, to the client. And so I want to actually bring up Cassidy McCurdy. Um, you can really, honestly, I think, fill out this conversation from the mentor, the coaching, the high level. I want to talk now to a practitioner who is filling her own cup. She's doing phenomenally. I want to learn about her cash pay pelvic health business and how she's actually providing such good care to people, as well as giving that care back for herself and making this care that we're talking about sustainable. Cassidy, welcome. Thank you so much.
Hi, thank you for having me.
Pivotal Pelvis, that is your company.
Yep.
That's your front door. Tell me a little bit about what you do and what you offer.
Yeah. I'm very fortunate to have mentored and continue mentoring with Danika. So she has definitely laid the foundation for me having the courage to open my own business. So I provide cash-based services, pelvic floor therapy to both men and women in Northern California, and really along the spectrum. I would say I'm more of just a generalist. There are more postpartum centered pelvic floor therapists where I live, but again, far and few in between. I think 4 in a 70-mile radius, 80-mile radius. And so I think I'm the only one seeing men, and I will see anyone, any age besides children. And one of my favorite soapbox conversations always comes down to the cash-based question and patients that get very frustrated getting the bounce around, trying to get insurance coverage. And I think, we had kind of mentioned a little bit, one of the big insurance carriers here, they're 5 months out booking. And so they give you a online tutorial to watch before you can even schedule an appointment. And so constantly I'm having to explain to people like why I'm a cash-based provider and why I'm so passionate about that.
So 40-mile radius, did I catch that right? You're within a 40-mile radius. You're the only pelvic health therapist.
No, so I am in the town that I live in. There's about 20 miles. I'm the only full-time one.
Full
Um,
time.
yeah. And then in about I would say 60-mile radius, there's 5 of us that are cash-based. 2 of us see men. And then I'm the only occupational therapist in north of San Francisco. I don't know how far north.
Amazing. Amazing. How long typically are patients waiting to see you, Cassidy?
I could see somebody tomorrow as of now. I'm very fortunate that I don't fill my schedule to where I have absolutely no time. And that was one of the things that I wanted to do in going to a cash-based business that I owned, was the freedom to have enough time to see my patients, have enough time to document, have enough time to answer questions for my patients throughout the week. Every single email or every single patient I see, I follow up with an email on what we did for the day. And I tell them before they leave, please, please, please text me if you have any questions. Text me if something comes up. And that's the benefit of having a cash-based provider, or at least how I practice is I want to help you if you have questions throughout the week. Don't wait until you see me next. You're going to forget. You're not going to get that care with an insurance-based provider, unfortunately.
They're able to text you.
Yeah, Absolutely.
I'm having a hard time only because I think I've been embedded on the other side a little bit too long. And I go back and forth. I really do. I try to spend time with you guys, but I don't get to have these conversations a lot. And you know that much of my audience knows that I'm talking to providers that are very embedded in their hospital system. They are insurance-based providers, whether they're seeing pelvic health patients on the outpatient side or whether they're seeing pelvic health patients after birth in the hospital or after pelvic surgery. And so the kind of thing that really gutted me this week was kind of having this conversation offline and online about whether or not hospitals are making enough money by offering occupational or physical therapy services to individuals in the hospital after birth. And I had a knee-jerk reaction, I'll be honest with you, because the highest that I got paid was $38 an hour at the top of my license. And this was after going through a residency at Duke University. This was, after taking a board certification exam that was like hard as hell. Like it was harder than actually getting my PT license. And this was after just years of just mentorship to just like finally give me the permission to feel like I was a pelvic health therapist that could treat men, children, and women, all diagnoses from cancer, oncology impairments, pelvic floor dysfunction, bladder, bowel, whatever it was. I was able to treat anyone who walked through the door, and I got paid $38 an hour. Now, most people would be like, why are you complaining? Well, most people don't realize that to be a physical therapist, you can hardly find a program that's under $100,000, by the time that you're done, boarding, travel pay, all of this stuff. And so when you're getting paid well beneath $100,000 a year, that's a mini mortgage. I mean, people are now in my cohort still paying on loans that are 15 to 20 years long. And so the burnout is very high, especially in pelvic health care, where women and individuals are waiting 6 or more weeks to see someone. So Cassidy, forgive me when I ask again, you're able to see someone tomorrow and you're not worried about whether their hospital is getting paid.
Yeah. And I have many of patients that are choosing not to go to their hospital or insurance-based providers. And I think a big part of it too is that relationship-based care is even on my free 15-minute consultation calls, I'm building a relationship with them. And it's not to make money. Like, yes, that's a huge bonus. Obviously, I got to pay my bills, but I'm so passionate about what I do and I love it. And I get on my soapbox with them. And I know it sucks that you can't get in there for months, but it's the relationship-based care, and it's that we're all in it. We agree the medical system sucks. But I think there are a lot of us out here that are just trying to make the best use of our skills that we can without having the constraints of a hospital-based system. I do per diem work, not as a pelvic therapist, but just as an occupational therapist at a hospital here. And once a month, I might get called into labor and delivery, maybe once a month. And it's typically maybe not like the most appropriate order. And it does. It just amazes me that these people are going home without the most simplest education. I mean, C-section, abdominal precautions, never heard of it. Like, it's not, I mean, yes, I understand the hospital being a system where you have to make money, and that's definitely a missed opportunity, but also, people are going to be coming back then because they're injured or they're worried that they now have cauda equina because something's going on because they did something wrong because they weren't told the proper body mechanics to have. And like, that's a huge disservice, money aside.
Totally agree. Danika, you were just saying that in your practice, you're able to set aside scholarships, do sliding based scale. I mean, you're able to have more freedom to provide equitable access to your services than most insurance-based providers.
Yes.
How do you do that?
1000%.
Like, how do you do that? Like, if you can be, even if you use just real numbers, how are you able to calculate what you're able to set aside to support someone who can't afford your care normally?
So typically what we do is when I started pricing out to include scholarship funding, I basically added 10%, 8% to that number so that I could be like, okay, now 10% is going here. Already having done all the numbers to figure out my income, my employee's salary, the rent, the operating expenses, all of those. Adding 10% to be like, no, we need to be able to be accessible to a lot of different people. So when we figured that out, we basically have 10% of all of our income go into a different account. And so within that account, there's a number. I don't know what it is right now, but there's a number that basically anytime somebody calls and they're like, hey, I need sliding scale. Hey, I need pro bono. Hey, I need this. We can look at that number and be like, okay, sounds good. So what we do is if pro bono, we typically offer the evaluation and 2 follow-up sessions, and then we kind of reevaluate. Because we have run into the problem where if you, I hate to say this, but if you give it away for free, people are less likely to be, on top of their stuff. So I don't want my therapist. I don't want to have to pay my therapist to not see someone who is supposed to be coming in to work with them. So basically we approve them at 3 sessions at a time, and then or eval and 2 sessions, and then another 2 sessions, and then another 2 sessions. So if they're on top of their stuff, I mean, we give them up to 10 sessions for free. And then when it comes to sliding scale, we'll basically offer them 2 different numbers. So we'll offer them $25 off at first, and then $50 off if the 25 is too little. And then if they still can't do that, we'll talk to them about what they can do. We also offer payment plans. So if you, sorry, my headphones keep falling out. So I've had it, I'm sorry. So with the sliding scale, I've had it as low as $50 because it was like this mom who was pregnant with her second. The kids were 14 months apart. Kid number 1, she was a neuro NP, and kid number 1 has brain cancer at 8 months old, 9 months old. And she was 3 months pregnant at the time. So like there was a lot going on in her life. And I was like, we're just going to get you in here to see you. I don't want this being considered. She was like, well, if I do pelvic floor therapy now, then I can save a little bit for like therapy later, like mental health therapy. So I legitimately called a therapist down the street who I refer to a lot, and was like, hey, I have this patient who said she can afford like $200 a month. What can you do? Because I'll do the rest. And so we literally split it, and we saw her each twice a month for $50, so that it was $200 a month. So being able to have the freedom to do things like that. And you know what? She's still a patient now, a year and a half, 2 years later, and she pays full price because she understood the value of it. And she was so thankful that she just continues to come back. So it's honestly a blessing to be able to do it. It's phenomenal when you're able to like make that difference for someone, because I've been there too. It's really hard when you basically cannot afford it. And it's not a game of, don't get your nails done and you'll be able to afford it. It's like, truly, there are times that one always gets me. I'm like, I understand that sometimes people are just really bad at budgeting, but also sometimes people have true barriers. I grew up with a mom who made $19,000 a year and raised 3 kids on that. We had true barriers. Like there was no way we would have been able to pay for that. So pro bono would have been the best way to go. And then the other thing we offer is payment plans. So basically if your therapist is like, you know what, I think 6 visits would be great, I think 10 visits would be great, we spread it out over either 4 or 6 months so that you can take the time to pay. And then there's a lot of people who will be like, well, let me come back in like 3 weeks because I can budget for it then. This way it's just a monthly payment for 4 or 6 months, and you can stack them all in the beginning if you want. You can spread them out. You can do whatever you want within that time period. So that also is a really good option for people who don't need sliding scale, but are still a little bit budget nervous about it.
Okay, Danika, you mentioned Profit First. Are you talking about the book?
Mm-hmm. I just started.
Wait, Cassidy, you're reading it too? You're reading Profit First?
Am I reading it? I just started it.
Shut up. Oh my gosh. I literally
it's what I tell all my mentees to do.
So I started that book last month.
This was recommended by another a chiropractor friend who's a cash-based provider. And so
yes,
good book so
Yeah.
far.
Yeah.
So great.
We have a whole mastermind on it in the mentorship program because like it's really important to know, and budgeting is freaking hard. And it's not something that comes naturally to a lot of therapists because we're just like, no, we just want to go treat people and lead with our hearts. And that's amazing. But it's also like we do need to budget. We do need to make money and have some savings for taxes and, you know, to pay yourself and things like that. Because a lot of practitioners will start their own business and then be like, but I'm just going to put everything back into the business and not take a paycheck. And it's like,
Oh
wait,
my gosh.
don't do
Danika,
that.
you are
Not
so
give everything for free. I think that's like one of the hard things to learn too, where like my time is money. Like I want to just do like all
Yes.
the community engagement things for free. And like I am fortunate that I had the time I could. And now I'm at the point where I'm like, okay, I gotta reel it in. Like now my time is filling up and
Yes.
I can't give everything for free.
No.
Okay, that's a game changer. So I'm going to take advantage of you, Danika, because this is just a little coaching session for me. I started that book because I enrolled in a business program, and
I'm not a
I have
financial
these.
guru, I will say.
Okay, all right, good disclaimer. But I
Mhm.
want to do kind of some high level coaching with you right now. Okay, so
Okay.
this is a little bit. I'm like not even paying you for this interview, but I'm just going to do it right now.
That's okay. No,
You
we
met
swapped,
Cassidy.
though.
Yeah, you met Cassidy as Cassidy. Were you an insurance-based provider? Were you providing pelvic health services? You came right out of school as a cash-based provider.
I was working in a hospital for 8 months before I decided I wanted to do pelvic floor therapy. So I was just in acute care setting. And then I found out what pelvic therapy was. And I was like, I want to do this. And I met Danika and I joined her mentorship program, and the rest is history.
How long were you an acute care therapist?
I was in acute care for about 6 or 7 months before I met Danika. And then I was just under a year before I quit full time. I went per diem and opened my own business.
Danika, do you have a lot of acute care therapists that come to you? There's a trend here, and I want to. This is kind of it going into my question, but I just have to like take a step back.
Not as many as you'd think. So it's interesting because actually, no, you know what? Thinking about it, it's probably the biggest populations I think I get are acute care, being like I'm either burnt out from just the amount of patients to see and just the fast pace of acute care. Or they need the freedom because they're having kids or because, you know, life is just happening. The other one is actually working in pelvic floor therapy clinics and not being happy with how they're providing pelvic floor therapy or how they're allowed to really provide pelvic floor therapy at their clinic.
Okay. All right. So here's my question, because I was that acute care therapist, and this is after I was that outpatient pelvic health therapist. So I went from the frying pan into the fire, essentially, right? I was seeing at the most of my day, 13 to 16 patients in the hospital, 85% of them after C-section, like hands down. Rest, high risk pregnancy, rest after endometriosis surgery, which was a real fast turnaround. They wanted those patients out within 24 hours, and then hysterectomy and prolapse repair, 24 hours. So I was burning through patients, and I know I was not giving any of my best to patient number 12 through 15. No way. I was going through that log roll. I was putting on the abdominal binder. I was telling the spouse, the caregiver in the room, this is how you help her out of bed. Boom, out. And now when I take a step back and just look at that, I'm just thinking like, there is no way they remembered anything I said. And I was sending them home to a situation where I knew hands down, they were going to have to wait 30 to 40 days before they saw a pelvic health therapist, if they even saw one. Right. Yeah. And so I knew that going into the educational part, I was going to be teaching acute care therapists who are in those situations, who are basically saying, if they're up and walking, you don't see them, they're not worth your time. And you'd be costing us money. So we really don't want to invest in your services. And so as I'm like in this world in between, I don't know how to get that mindset over to where I shifted, which was private hospital. I became a therapist in the community that could actually go into the hospital, not as a doula. I did do doula training, but I actually went as a private physical therapist and saw women in the hospital within 24 hours after birth and surgery. And I said,
That's
okay,
really cool though.
cool model, right? But then when you are transitioning someone out, how how did they even get started? Cassidy just said within a year of quitting her job, she started her own business, right?
Mm-hmm.
Like what was the driving force? Was it what I saw, that pelvic health populations are just literally getting the worst of the worst care, which I believe they are. I will go on the record and say that in this country today, if you have a pelvic floor dysfunction, you are getting the bare minimum care in terms of traditional healthcare. It's awful.
Yes.
Unless you are seeing someone like you who is raising the bar like super high. Cassidy, what was it for you that said, I am not going to work in this system anymore? I'm not going to do this.
I think it's that genuine autonomy for the patient. You know, me as a provider, of course, I want to be able to do what I want, but we need to be giving the best care. And that's whether the patient is paying out of pocket or not. I'm wasting my time if I'm, working in an acute, like you said, acute care setting, and I go in there for 15 minutes and I tell you something that you are not going to remember for whatever reason, and I leave. And I'm wasting your time. I see people and we're doing the same thing over and over and over again in a session until they are comfortable with it. And if I have a plan, we're going to do treatment A and B today, and they come in and they want to do something totally different, then that's fine. That's what we do, because that's what's important to you today. That's what's going to make the difference in your life, your quality of life, your quality of care, and your occupations. Like that's what's important to you. And that's where we need to shift the perspective. And, pelvic therapy specifically is peeing, pooping, sex. Everybody does some form of those things. And working in a hospital setting, I was finding nobody's talking about these things. And that was really my big shift into going into pelvic therapy. Was I had a younger gentleman in his 40s with a spinal cord injury, 10 years of bowel dysfunction issues. And he had another spinal cord injury or another spinal surgery. And I said, okay, well, have you pooped since you've been here? And he's like, no, I've been having these problems for years. It usually takes me hours to poop. And I'm like, okay, well, are you doing X, Y, and Z? He looked at me like a deer in the headlights. And I'm like, well, let's go sit on the toilet. Let's check out your body mechanics. Are you doing this? How's your diet? And he just starts sobbing, crying. And he's like, I've been going to a GI doctor for years. Nobody's ever asked me these things. Nobody's ever showed me these things. They've given me medications. And the next day I went in and he was like so happy. He had all these things he wanted to try, all these questions. And I'm like, this is the care that matters. Not going into somebody that doesn't care what you're going to do when you go home, what your house looks like, what your setup looks like, what your routines are, what you want to do. And that's absolutely what I love. Is I spent a whole hour session today working with a mom getting up and off the floor, because that's where her radiculopathy starts, is when she's on the floor in lactation support group. Insurance typically is not going to cut there. No, that's, do manual therapy and exercise to resolve it. But that's not the root cause. The root cause is her sitting cross-legged on the floor with a pelvic tilt. So there's my roundabout soapbox.
Yes. Okay.
On it.
I told
So
you
it was care. It was care. I mean, what I got from that was it was the level of care that you were saying you refused to be in it any longer.
Yeah, I'm not gonna sit there and just checkbox everybody. Not everybody's just a number.
Yeah,
Danika,
I feel like the only time we ever talked about bowel bladder sexual dysfunction, because I worked in inpatient rehab for a while, was like the FIM. And then it was done.
Well, I talk about it all the time because I still do per diem in acute care. I'm in there, I'm like, have you pooped yet? Okay.
Now I would. Yeah.
Yeah, all the time.
Wait a second, I'm sorry. You're an occupational therapist. I brought you on here for a reason. What are you talking about? That's the only time you ask somebody if they pooped. Really?
I say in acute care, I'm spending most of my sessions in the bathroom.
Right.
That's fair. No, in inpatient rehab, it was more especially the sexual dysfunction, not so much the peeing and pooping. That's, you have to go over that anyways. But with the sexual dysfunction, that was a big piece of it. Is the only time it would ever get addressed was by OT during the assessment portion, and then during maybe a home eval or if the patient brought it up. And that was the only thing. And even half the time, if the patient brought it up, I remember having a 26-year-old who was in a motorcycle accident, spinal cord injury, I think it was C6 level. And he was like, how do I have sex? And I was like, that is a great question.
Right.
I'm going to go look it up. And like, I spent a lot of time deep diving into stuff, into positions and all these different things, because the program that I was in, which was at a huge academic hospital, did not have like a spinal cord sexual function program, anything. And I was like, how is this possible? How do we have a spinal cord program, but we don't really cover that? Like, that doesn't make sense to me.
Right.
But yeah,
Okay.
it's the level of care is definitely, it's so hard to be able to be on that much for 12 to 13 patients, right? Like you
12 to,
can't.
yeah.
It's
13 to
impossible
16
unless
patients
you're
you
a
need.
chiropractor and you have 10-minute sessions with patients. Like,
Right. You're doing all
it's
manual
not a
therapy.
thing. Yes.
So here I am, and this is kind of my big coaching question. I just want to ask you both. I have to get this out because I know that what I'm teaching acute care therapists to do, and even home-based therapists, mobile home, virtual care therapists, doesn't matter, is to fill this huge gap, right? That we both know is there in the insurance-based world. Like from 0 to 6 weeks, like not you guys, but I do want to ask, like, what's the earliest you would see someone after pelvic surgery or after birth? But right now in the insurance-based world, I'm hard pressed to find a pelvic health therapist that will say, yeah, I see them at 2 weeks after birth. Oh yeah, I'm talking to them. Even virtual therapists. I'm just like, yeah, we can't really see them until, 6 weeks until they see their doctor. And I'm just like, excuse me, what? Like, there's
Even
so much you
virtual?
can do. Even virtual. I'm
What?
telling you, these conversations are happening
My
open, in
eyes.
the open. Even
Like,
virtual
what?
care therapists are
No.
seeing people. I'm not joking, are waiting 6 weeks to see someone after birth virtually. Okay. So when I
No.
tell you about like the interventions, it sounds very generalized, right? It doesn't
Yeah.
sound like it's traditional pelvic health therapists that are treating these individuals, but they're looking at the holistic person. Like they're looking at the mom who's sitting cross-legged on the floor,
Yeah.
right? They're looking at lactation positions,
Yes.
and they're looking at extra childcare, lack of sleep, all of it. But they're working in these systems that don't allow them to make their services widely accessible. And so
Yeah.
my coaching question for you is, what could you like provide in like kind of like a 2-minute bit to an acute care therapist who wants to start to inch out on their own? Like, where do they
Ooh.
start to provide cash pay pelvic health services to
Yeah.
fill this gap? Because it's huge.
No, that's a great question. So to fill the gap between that like 0 to 6 week
Absolutely.
mark.
Yep.
So one of the things that I would, especially with the FTC getting rid of non-competes now, which is
Heck
wonderful.
yes. I'm happy about that.
I
Yes.
know, I'm so excited. I'm so excited. I have never put non-competes in my contracts for my employees because I'm like, no, if you find something better, it's my job to match it. But anyways, no, so if they are interested in seeing those patients and continuing to see those patients, let's say they get really inspired by like somebody who, had a really, really tough C-section birth, or, a breech delivery, something that was like, holy moly, mind blown, like, I want to do this. I would highly recommend just kind of talking to the patients that you're seeing in the hospital and being like, would you be interested in me coming to you? You know what I mean? Like build that rapport a little bit and gauge interest in that. One of the other things that you can do, it's either that, so you can kind of build from the ground up, kind of more of a grassroots campaign. The other option would kind of be coming from the top down and be building some branding, building some, if you kind of know you're going to get out of acute care anyways, or you're like toying with the idea, because remember, you never have to go all in on a business. You can go 50%, and that is okay. So if you do top down, get your branding, get your marketing materials, talk to some other professionals in the field, like in, OBGYNs, midwives, connect with people, create those relationships in the community, and then talk to the patients that you're seeing in acute care and be like, hey, I actually have this business. If you want information, I can give it to you. You'd have to run that by the hospital. But You could definitely try to kind of on the DL or be like, yeah, I have an Instagram, go follow it. Something like that. That would not be, and keep it on the low, on the DL for that. But you could also talk to the OBGYNs, talk to the midwives that are running this shindig, right? And basically
Right.
be like, hey, I am providing these services 0 to 6 weeks out too. We're not doing internal because obviously pelvic precautions, but we're going to be doing everything else. We're going to be screening for mood disorders. We're going to be taking blood pressure, right? We're going to be reducing risk of postpartum preeclampsia. We are going to be helping your patients heal better and create more functional outcomes for your patients so that they can come back and say, yeah, my OB was fantastic, because they're going to associate that with a good birth. So especially with anybody honestly, with anybody, I mean, I can't think of a single person who wouldn't benefit from that. But there are therapists out there, including myself, who see, very newly postpartum. I mean, I will go 24 hours out and go see them after a home birth. Go screen their infant
You do
for
that
tongue lip
now?
ties. Yeah, yeah,
I saw on your website that you do tongue,
yeah.
you do tongue tie
Yeah,
disorders as
tongue
well.
tie, lip tie, infant tension. About half my caseload is infants, and half my caseload is pelvic health at this point, because
Danika, I did not know you were
pediatrics is
doing
what I
home
started at.
visits.
Yeah, yeah, yeah. So we do home visits at, like, for Flourish. All of our therapists do home visits. And then when I go out on maternity leave, because I'll be going out in 5 weeks now. I
Congratulations, by the
know.
way.
Thanks.
Yes.
We're taking, side note, I'm taking 8 weeks out because I'm not doing until August, but I was like, this preeclampsia has kicked my butt both times already. So we're gonna take
Really?
8 weeks, and I'm gonna go swimming in the pool every day.
Yeah.
I'm gonna read books. I'm gonna not do anything except for like run the business and virtually and like
Yeah.
not treat. It's gonna be a break. But anyways, it is really, really, really beneficial to look at that mom and baby as a dyad and be able to treat the entire person. And so if you feel drawn to that as an acute care therapist, and you are like, maybe you're seeing patients on the L&D floor that you're vibing with and you're loving this stuff, then go for it. Just go for
Yeah.
it. What's the worst that can happen? Develop an LLC so that you're kind of protected. Get your malpractice to make sure that it covers your LLC, and then just do it.
Oh my gosh, did you just say malpractice? I mean, you know what? I have these conversations and I have to take a step back, and I'm just like, I'm talking to people that don't even realize, as an acute care therapist, if you're treating on the L&D floor, you should have your own malpractice insurance. I don't care what your hospital covers. And
Yeah.
I have to take a few steps
No, your
back because
hospital.
their hospital protects themselves. Like,
Yes.
it's such a weird, like, transition
Mhm.
that I'm in, because I am giving my heart and soul to this population of therapists because I believe what they do. People don't realize that my story actually started with my mom. And I've been open about her stroke that occurred 3 months before I started PT school. And she had insurance. I had her purse. She had the Cadillac of insurance, y'all. Cassidy, when I tell you, she had Cigna that would have covered everything. But in the panic, I'm watching her lose function. She's not, walking, and she's not speaking. That I don't realize 36 hours later, they're withholding interventions because they think she's indigent. And so when the social worker comes into the room, the case manager, he corrects the OT and PT that are there evaluating her, recommending inpatient rehab at JFK, which was like phenomenal rehab hospital in New Jersey. And he comes up behind them and says loudly, she's not eligible. She has to go to a sniff. And I was like, I knew enough as a rehab tech to know I call bullshit. What the fuck? What are you talking about? And I pull out her card and his eyes get so big. I will never forget this moment in my life. Runs it, obviously, she has great insurance, approves her, and it starts to make sense. They looked at my mom and decided she didn't have insurance. So when people are talking to me and they think I'm on the insurance side versus cash pay, I'm like, no, you judge people based on what you think they can afford. I see you, right?
Mhm.
And my mother would have paid had she had the option. I mean, we would have paid as a family if insurance didn't cover. We would have covered
Needed
that
to.
gap.
Yeah.
But people will judge people based on what they think they can do and then offer those services, thinking they're doing them a service. And I'm like, no, you're actually reducing their access because you're deciding for them what they can afford, right? And she
Yeah.
had severe incontinence, right? And so I think a lot about this pelvic health conversation. It's a bigger issue for healthcare because we're doing this to women during pregnancy, after birth, after pelvic surgery. We're withholding services that we would give to somebody after an ACL repair, right? And we're telling them that in the first 6 weeks, either we're not going to pay for it, we're not going to cover it, we're not going to provide it, we're not going to train our future therapists to treat you, right? And so for you to be telling me, Danika, that you do home visits within 24 hours and your therapists who work in your practice do the same for this population, Cassidy, within a year, you were able to start your own business, profit first, like taking care of yourself, right? To me, this is a futuristic conversation. I realize that. But I'll be honest with you, I've been in this kind of like holding pattern because I really do believe in acute care therapists. But I know I'm going to have to pivot towards those therapists who have no limits, who have no barriers in terms of the people that they want to serve. And you guys are giving me a lot of like meat to kind of go back to my community. What I really want to know is, do you have capacity to mentor? These therapists kind of out, because it's a lot. I understand it's a lot to start with, like malpractice and LLC. Like, where are therapists? Where do you usually want them to be before you start mentoring them?
Honestly, they can be wherever. So, like I do a VIP mentorship, which is like 1-to-1, twice monthly calls with me. It's like a 4-month like sprint. And so I typically only take 5 at a time there. And then the mentorship community is just kind of open, and it's a group mentorship, and it's business masterminds and coffee and chats and clinical skills and all the things. But I have had everyone from students who are interested in pelvic health kind of do the clinical side of the mentorship and be like, this is really cool, to one of my VIPs right now. She graduated in December from OT school. Like, she graduated with her master's in December.
And went right into your community.
And she literally worked for a place for like 3 months and was like, this is awful. I'm building my own.
Hey.
I know.
Okay. And Cassidy, are you at the point where you are like in the community and you're kind of almost like a co-mentor, if you will, like you're showing it, like you're actually demonstrating that this can be done?
I think it's like a huge passion of mine. I absolutely love community engagement. I probably overdo it a little bit. But I think, that has been part of growing my business, though, is I very intentionally went out and met every person I could that would potentially be seeing a patient that I could see. Doulas, acupuncturists, midwives, nutritionists, mental health specialists, chiropractors, physical therapists. I could go on and on. But of course, like, I want to get patients, but like, those are the people that also want the education and like looking out for those signs of helping and giving people access. And it naturally becomes that way too, where I have other occupational therapists in Northern California reaching out and like, how do I do this? Like, how did you even get into this? And I also just wanted to kind of comment on something you said, that as cash-based insurance providers, I think, or cash-based providers, we just have to make ourselves valuable enough. And I talked to Danika in our mentorship group about this week, that I just recently got a patient with workers' comp, and I don't take workers' comp, but this patient advocated so hard that they wanted to see me, and I was the only person within like a 15-mile radius, and workers' comp was just like, yep, go see them. You have all of your visits to go see them. I don't have to do anything else. They just get to come and see me, or I'm doing home visits for this person. And like, as a business owner, I get to make that decision. I get to decide how many visits a week, then like, how are we going to use those 24 visits? And that has been just establishing the importance, I think, also in the community, because, I'm meeting attorneys and other people that are seeing, oh, pelvic floor therapy is a specialty, and it doesn't need to be constrained by insurance and bound into this system.
Wait, Just back up.
Well, this patient's
Workers'
really
comp
cool.
is
It's a
paying
cool
you
case, too.
outright?
So the patient pays, and then they reimburse her 100%. And they authorized
So
her
you
to
never have to deal with the third party.
Nope, not talking at all. I got email proof that this is the agreement from the attorney and workers' comp. That goes in her chart, and that's their agreement. She pays. I give her her super bill, and I see.
We have a similar one from a car accident right now.
Danika, wait, can you guys just go high level with me? You're talking about this is patient driven care. I'm serious, y'all. Like Uber already, like Uber, Airbnb, like those models work and they're sustainable because patients and clients are driving the services that they want. They're literally in their hand. They're choosing where they want to go and who they want to take them there.
Well, I think that's
healthcare is so like we decide where you're going to go and how you're going to get there.
I advocate so hard for anyone that calls me just for a question. Simple question. Do you take Medicare? And I'm like, no, I don't. But here are the local providers that do. And I just yesterday, she's like, I had Medicare and they wanted to charge me $100 to see them. And I have Medicare and blah, blah, blah. And at the end of our conversation, she asked how much I charge. And I was kind of nervous to tell her. So I'm like, I charge a lot more than $100. And she was like, okay, sounds good. Then she's going to call these other people. But, I think too that like I tell these people, okay, I want you to call insurance. I want you to say these things, and I will send you my CPT codes that I use. And if you don't want to see me, here's insurance options. And I think sometimes I get people that come back because of that. Again, that relationship-based care. I'm advocating for them, showing them that like I do care. And I'll do what I can to help you get the services that you need, even if that's not me. I have referred patients that I think would be way better with another therapist somewhere else, just because of what like level of care they were needing or what they were looking for. And I think there's other providers and therapists or other therapists in the area that do that. Like we want client-centered relationship-based care, and that's okay if that's not me.
Well, and I think a lot of that plays into authenticity too, and feeling confident in your skills and your business, right? And so making sure that you're telling patients that, yeah, there are other options. Absolutely. And you know what? If you're not seeing progress within maybe 3 or 4 sessions, give me a call back, you know? Because especially if a patient has like a $20 copay, right? Not co-insurance, like a copay to go see a physical therapist, and they're covered in their clinic. Like, yeah, I'm not going to beat that. Go ahead. You know what I mean? But if you're not seeing progress within 3 to 4 sessions, because you see progress quickly with pelvic floor therapy, typically, just give me a call back. Maybe we'll do 2 sessions together and see how that feels. Like, see if you're going to make any more progress. See if we're asking the same questions. See if you notice a difference in care. But the fact that they feel comfortable enough to call back, and I'm giving almost giving them that permission, right? Of being like, hey, I've seen this before, just so you know, it's not an uncommon thing, but like, if you want to go try there first and then come back, that's fine. They're like, yeah, actually, I haven't seen much progress. I'd really like to come back. The sessions are only 45 minutes. I'm with an aide half the time, Like, that's kind of what you're going to get. I'm sorry. So then they usually come back.
Just to clarify, you're not charging for your consultations?
We do like free 15-minute discovery calls. I have spent lots of time on the phone with patients or with patient leads.
So what you're essentially doing, and I have to recap because mind blown. You're essentially talking to people. You're doing the research of who in their community they can see that takes their insurance. You're teaching them, like you'll actually teach them to call their insurance company, which there are not a lot of front desk people who even do that. Call your insurance company, here are the codes that we bill, and you can see if this is covered and by how much and all of it. So you're teaching them on the phone while you're consulting. They choose an insurance-based provider. You're like, I've given all this information. You feel good about that. And they're likely coming back. They have come back to you because they had such a good experience. They felt that they were seen and heard. They either waited a long time to see the pelvic therapist down the road. Maybe, those outcomes were poor. Maybe that therapist was seeing someone else within the hour. And at the session, my clinic, if it was 30-minute session, we were rushed to kind of, move through the session. And we have some pelvic health therapists that are practicing in still in facilities that are more kind of outpatient ortho based, like Factory Mill, where they're doing 30-minute sessions with their pelvic health clients. I was lucky to have a job that allowed me an hour, but it was still pretty overwhelming because I knew another patient was right behind. And if this person had trauma, I didn't have buffer, right? I didn't have a lot of buffer time. So what you're saying is that in your consultations, which probably go over 15 minutes, you're giving all of this attention, right, to people, and they're coming back willing to pay more for the care that you provide. You're also able to see people.
And I think that relationship, especially when it comes to pelvic floor therapy, you need somebody that you vibe with. So even like anyone that talks on the phone, if you're not vibing with them, like oftentimes, you know, it might be a better option to hand them somewhere else to be like, you know what, we're not taking any new patients right now, or like there's an 8-week wait list or whatever it is. You can tell them whatever you want, but like if you're not vibing with them, that's really important to know about yourself and know about that patient. That is actually a point that I make when I'm hiring, because I'm like, I need people of different personalities, right? So that everyone can vibe a little bit different with somebody else. And so it's really important to be able to do that, because you're building that relationship so quickly, and it has to build up and up and up so quickly that they trust you with, I mean, the center of their body. You know what I mean? They're going to be carrying trauma, most likely. They're going to be carrying an emotional healing journey with them, and that is going to look a lot like a reflection on the relationship that they create with you.
Yes.
So it just, it blows my mind when, I mean, I did 45-minute sessions for a while and it was awful.
What are your session times now, both of you, as we wrap up?
90-minute eval, 60-minute session.
Sorry, what?
90-minute eval, 60-minute session.
Same thing. Yep.
Cassidy, same thing.
Same thing. Yep. And I'm seeing maybe 4 to 5 a day. It's a good place.
That's so healthy.
It's so
First
healthy.
of all, I will say
infant or pediatrics, it's 60-minute eval, because they don't usually do great with 90 minutes.
Also, are they
no.
as much?
As a pediatric pelvic floor therapist, no. You know. I'm talking to Danika Viola, owner of Flourish Pelvic Health and Wellness. Cassidy McCurdy joined us midway through, owner of Pivotal Pelvis. I'm so overjoyed that you both spent time with me talking about cash pay pelvic health, talking about the barriers, and also sometimes the access that insurance-based providers do provide to their patients. But in general, pelvic health care, where is it going? My last question to you both: where is pelvic health care going? Where do you see it? What makes you excited? What are areas, gaps in care that you want to fill with providers who are taking care of themselves so that they can take better care of their patients? Danika, go first. Where's pelvic health care going?
So I will say, as a pelvic floor therapist for 8 years now, because I've been an OT for like 11, pelvic health for 8. The amount of OTs and PTs and CODAs and PTAs getting interested in pelvic health and seeing the immense impact that it's having on the general community is astounding. And it is so inspirational, because I no longer have to explain what pelvic floor therapy is to like half of the patient leads that call me. It used to be that they would pick up the phone and call, and they would have no idea what they were coming in for. They would just show up for an evaluation and be like, wait, what? What are we doing here? They had absolutely no idea what a pelvic floor was. They had nothing. And so the impact that we are creating as therapists is bleeding into the community, which is absolutely incredible, because that is where it needs to go, is to the community. Because as we were talking about patient-directed care, like, they are the ones advocating for yourselves. And Rebecca, I know that you say all the time, like, the patients have to ask for PT and OT in the hospital, right? That is how those acute care programs get started. And that is something I will be doing after I birth this baby. at my hospital, because I will be right on those midwives' asses, to be honest, about being like, hey, PT or OT, let's go. Because it is just, it really is up to the community to be able to start to advocate for their own health. And as much as we can do, I think a lot of that lands back on education and feeling empowered as therapists to be able to do this, and also empowering the community to ask for it and to know when it's appropriate and to know what the heck it is. So I think we're still there, but it's growing like crazy, which is phenomenal to see after 8 years of being in this field.
Awesome. Cassidy.
Yeah, I mean, I second everything Danika said. I absolutely agree with. I think the other part is too, we talk about us seeing moms, as moms have to take care of themselves to be better moms, better parents. And that's the same as therapists. Like, we have to take care of ourselves to be better therapists and be better to our clients. But I think people are definitely talking about pelvic floor therapy more. People are talking about just pelvic health in general more, both men and women, and providers are as well. I think there is a bit more of receptive discussion. I'm very, I'm new to the pelvic floor world, but I'm seeing that engaging in conversation with people that maybe haven't been open to it before, when I'm in terms of providers, they're definitely more receptive to the conversation and education. And what I'm oddly finding, actually, especially with this recent spinal cord case I have, is every single provider on that person's case is like, well, have you seen your pelvic floor therapist? And she's like, they are all expecting you to solve everything. And which is kind of scary. But then a little bit, I was also like, well, that's amazing. That means that they're putting value in pelvic floor therapy, and they're seeing that like that. I was very scared and nervous, and I'm like, okay, so your spinal surgeon, your GI, your urologist, your urogynecologist, every single person is like, what's your pelvic floor therapist say? I'm like, but I think that's amazing. Like, that's great. And the other big part too is we're getting more people talking about it in the community, and more people talking about it to each other and going back to their providers. I always ask my patients, tell your providers your experience. Not only, hopefully they refer more people, but those providers are going to tell their friend providers. And, that's how we just kind of keep the circle going. We talk about it.
I will end with this. And Danika, this is because of a throwback, and I just have to throw back to what you said. I was that acute care therapist that worked in the hospital, could not compete. Referrals had to be made to the outpatient pelvic health therapist. But I had a patient who had a horrible, unexpected cesarean section experience. And her mother was there. And she asked me straight out, what do we have to do for you to come and provide home care when she gets discharged? She did not want her daughter to leave without some assurance that she would be followed up by me, because I was providing the care that she would expect anyone after that traumatic of experience to receive. And it was a shock to them both that physical therapy was even being offered. And to me, it's a shock that occupational therapy isn't standard of care. Like, I just have to say that, especially after C-section, just any major abdominal surgery, spinal cord injury, all of it, we just kind of muddy the waters, with these procedures, and it just becomes a no-brainer. We're going to offer rehab, but when it comes to the maternity unit, we're not even a thought. Occupational therapy and physical therapy is not there. So I do see there's a lot of potential in that area, but what I see even more is what happened in the community. When I received my first call from a patient who was going in for an expected cesarean section because of a very traumatic first vaginal delivery, and she asked specifically to have a physical therapist or a pelvic health therapist be her therapist in the hospital, not a doula. That's the future. You are absolutely right. Patients are going to be driving care. They're going to be so knowledgeable about pelvic health care that they're going to choose how they want their experience to be. And we're going to receive more of those calls. We just need people like you who's, accessible to train the next generation of therapists, because they're not getting it in school. They're not.
No. I didn't even know therapy was in school.
No.
No, me neither.
Even business basics. I'm telling you, LLC and malpractice, the fact that I even have to tell acute care therapists, carry malpractice insurance apart from your hospital. And it's just like,
And if you have an LLC, make sure it covers that too.
Right? Yeah. So there's a lot of education. I feel like both of you, Flourish Pelvic Health Community, please, where can people find this community? Where can people find you?
Yes, so the clinic is I'm outside of Philadelphia. However, the Flourish mentorship community is based at flourishmentorship.com. Is the easiest way to find us. And you're always more than welcome to email me. We have a contact form on the website. Or you can just email me at danika@flourishmentorship.com. And then Instagram is always a good one too, because I do get back to DMs all the time.
And are you taking physical therapists? You don't discriminate, right?
Right now, the community is only OTs, but I have actually had a lot of requests. And really the only reason that we were doing only OTs was because that's where my, obviously, credentials lie and that's where my expertise lies. But also because OTs tend to feel a little more like, well, I don't want to feel like I'm just I'm like a PT in sheep's clothing, right? Like I don't want to feel like I have to fit into this box. Right. So how can I feel like an authentic OT doing pelvic health? And so it's as Lindsay Vessel says, a double horn unicorn. So
we have to talk about part 2 after baby down the road. Congratulations again, but we have to talk about that because I just went to my first Lindsay Vessel.
Yes, I saw that.
Conference. I'm telling you, there is so much rewiring that's been going on. But
just wait until you see the stuff from the Pelvic Health OT retreat that we're running next weekend in North Carolina.
Get it? I'm a believer. I've drunk the Kool-Aid. I'm a believer. And someone said that to me. I'm a believer. Acute care after birth. And I'm like, you haven't seen anything. Once you see occupational therapists practice pelvic health, you're a changed person. You get it. You just get it. Trauma-informed care is built into your practice.
Yes, you cannot do pelvic floor therapy without trauma-informed care.
And we say we practice it, but I'm like, no. If you're using a biomechanical model in your pelvic floor dysfunction assessment, and you haven't asked somebody how they feel about, actually going home at this point after that trauma, or you're not taking that time to really explore how are they coping, and you're going right to the log roll and you're going right to the incision protection and all of this, and you have to do the thing. And it's like, you haven't taken that time.
No, being able to provide those coping strategies and being able to provide those strategies to help with trauma responses, right? And knowing how to recognize trauma responses and educating patients on that. It's a big deal. And it's something that in OT school, a lot of OT schools, I don't know all of them, but it's not a blanket statement, but like most OT schools, we get a lot of it because mental health is such a pillar, and OT really started in mental health, right? So
you actually have to do a rotation in mental health. You have to do
not every program. Like I went to Ithaca College in upstate New York. We did not have to do one in mental health specifically. I did, but we did not technically have to do one.
Amazing.
Different because we had to do a level 1 in mental health.
Okay, different programs.
Yeah, different programs, different requirements, but it's definitely, it's in the curriculum. You have to learn it.
Amazing. Thank you both.
Thank you.
Thank you, this has been wonderful. And stay on with me. We'll chat offline.
Okay, sounds good.